Thank you very much. And I'm very grateful for this opportunity to present our work here. This is the result of a collaboration between the BC Centre for Excellence in HIV/AIDS, especially contributions from the laboratory program, as well as our partners in public health in British Columbia. I have no conflict of interest to disclose. This is going to be about phylogenetic clustering. This is a method that's become pretty mainstream now, which is great. So most of you are probably fairly familiar with this idea. And the idea is that this has become a popular way of characterizing the transmission history of an epidemic. So HIV evolves so quickly that there's a measurable change that accumulates over the course of a given infection. And so when you see two infections that are genetically similar, that tells you that those are related by one or more recent transmission events. So what we're going to do is build phylogeny and look at how those infections are related, and then look for short branches in that tree. Clusters of those short branches indicate that that's where the epidemic has been moving quickly through a part of the population that's burdened by a higher rate of transmission. So the BC Centre for Excellence in HIV/AIDS is responsible for all routine HIV drug resistance genotyping in the province. We also do a fair amount of genotyping for Canada as well. Genotyping now under current treatment guidelines is automatically performed on all new patients' baseline samples that are submitted for viral load testing also at St. Paul's. So this means that there are data available for roughly 3/4 of the about 11,000 people who have ever been enrolled in this drug treatment program in British Columbia. This represents over half of the estimated prevalence of all HIV-infected individuals in the province. All of the de-identified genetic sequences are, we have roughly 32,000 sequences now from British Columbia, are deposited in the drug treatment program database and linked with anonymized clinical, demographic, and risk factor data. So what I've been doing is developing an automated system that talks to this database. Whenever the laboratory uploads new sequences, then it reanalyzes the entire database, all 32,000 sequences. The lab is producing roughly 10 to 20 new sequences a day. So there's a lot of new data coming up constantly. So when it detects these new data, it performs an extensive phylogenetic analysis of the entire database. It determines if there are any new cases that appear within these phylogenetic clusters. We define a cluster as having a minimum size of 5 individuals. And then it generates not only daily reports, a report whenever it's done in an analysis, but also monthly and quarterly reports. These are issued to center directors, the BC Centre for Disease Control, and the the health authorities of the province. These reports outline the growth dynamics of active clusters in that time period, as well as the characteristics of each cluster. So this busy diagram just gives you some of the information that's being presented in one of these reports. This is an example of cluster 0. It's the largest cluster in British Columbia, comprising mostly injection drug users. Each of those circles that you see, it represents an individual. The size of that circle is scaled to their most recent viral load. So we're looking for the larger circles. The small circles correspond to individuals who have a suppressed viral load. Circles that are grayed out represent deceased individuals. A line is drawn between two of those individuals if they have sequences that are within a minimum, a given phylogenetic distance, a given distance separating them in the tree. That implies that they're related by recent transmission events. The circles are color-coded by transmitted drug resistance, and so green means that there's no evidence of transmitted drug resistance. Red means that there's resistance to one or more drug classes. And new cases in that time period are indicated by a double outline. So there's that one, actually there are a few new cases here, here, and here in this given time period of 3 new cases appearing in cluster 0. We also impute dates of seroconversion, which allows us to reconstruct the growth dynamics of a cluster over time, indicated by the blue line. Subtracting out deceased individuals gives us the prevalence of that cluster. And then something that our partners in public health found to be important was reporting the current number of individuals with a detectable viral load, and that's indicated by a big red dot to make it nice and obvious in this plot. We also do geographical mapping. So this is cluster 0 maps to an exploded diagram of British Columbia. Each of these regions corresponds to a collection of postal codes, essentially, that represent in a rural or urban area. The reason why I had to break the province up like this is that there are large swaths of the province where there aren't really a lot of people. So the north has been shrunk down to a very relatively small piece, whereas downtown Vancouver and Victoria have been expanded so that we can see what's going on. This is an active computer-generated diagram, so it communicates with the database, and when there have been a number of new cases in a given region over time, here in the last 6 months, if there's one recent case, then we highlight that in yellow. If there's been 2, then it's orange. If there's been 3 or more, then it's red. So this is a fairly widespread cluster in the province for this particular example. So about June of last year, something happened. And that was that the system reported the growth of a cluster that was roughly about 27 cases by 11 new cases in the space of 3 months. 8 of those 11 new cases carry transmitted drug resistance, and specifically that was K103N, which confers resistance to NNRTIs. This was shocking, and so it was reported to the directors and so on, and onward to our partners in public health. It prompted a formal outbreak investigation, and then an enhanced public health follow-up that was supported by information from this system. That resulted in partner notification services being offered to the affected individuals, and ultimately the re-engagement of an HIV positive contact engaged in high-risk behavior back into care. In addition, this is a before and after diagram. This is the cluster that triggered this outbreak investigation, and this is the subsequent state of the cluster in the period July of last year to January of this year. Most of the new cases from that previous period achieved a suppressed viral load, which was great news. Also, there was one new case that appeared over that entire period in early August. That infection probably happened before the outbreak investigation, so we were feeling pretty good about ourselves. Then this happened. So because this is a near real-time monitoring system, it's always watching the database, and so we were watching this gradually start to unfold again in the period spanning February and to June, by which time I had already submitted my abstract to IAS. So there were 7 new cases. One of them carried a K103S, and we have resistance to 2 drug classes in one of these new individuals. So that was disconcerting. It did teach us a lot of lessons. One of them was that the phylogenetic monitoring tends to confirm what is at least suspected in the public health population. They're very good at knowing what's happening in their population. So when we report that something is happening in a cluster, it's largely confirmatory, like, oh yeah, we know that there's something going on. And so we're able to, in fact, provide a more supportive role and provide information on minimal information for unmasking clusters at a group level. We emphasize working with least identifying information only when it's warranted by the circumstances. Placing this emphasis on the group level information helps protect individuals from the misuse and misinterpretation of these data. There are also several security safeguards built into this system, such as re-anonymization and secure deletion of data. And finally, this resurgence of new cases in this particular cluster warrants continued monitoring, and so we can't become complacent. We have to keep an eye on how things are going over time. Finally, this is helpful because it's difficult to obtain timely information on recent dynamics in an epidemic. So this real-time monitoring that's making use of data that we're already collecting over time routinely, it makes use of this population-wide resistance database and allows us to maximize the use of our resources. And hopefully with one of the main objectives with this is preserving treatment options in the province by detecting and averting transmission of HIV drug resistance. So I have some funding support, and thank you very much.